So I'm a multi-specialty NP, which means I work throughout the hospital. As you guys know, we're all kind of ER nurses, which means you have to be specialized in a little bit of everything, right? You see everything that goes on. So I feel like they kind of took advantage of me when they did this, because they're like, oh, well, you can do cardiology, you can do all this stuff, pulmonology, and I'm like, okay, let's take this a little far. But my true passion and my fellowships are actually in pediatric mental health. It's one thing that I absolutely love. Learning objectives, how many people are NPs in here? Okay, and then nurses as well. So one of the good things about this lecture is it's going to cater to both, which I'm really excited about. We're going to recognize acute behavioral disorders, presence in pediatric mental health disorders, apply non-pharmacological interventions to de-escalate pediatric acute care behavioral cases, identify pharmacological options as well. What's important to know is that we're not just going to specialize in a specific one of these. So we're not just going to give a medication. We've got to work to incorporate all these into this. Statistics over a 10-year period. So a little bit, the last statistics I could find was 2011 to 2020. 7.7% of all pediatric ED visits, which made to 7.5 million, was related to pediatric mental health disorders, okay? There's been a sharp increase since COVID as well. Would you guys all agree that we're seeing a lot more of these cases? We are. Social media and the acceptance of mental health plays a factor in this, okay? You see TikTok, you see these kids coming in on TikTok that are seeing this more as an acceptable thing. So at one point, you know, maybe a little bit on the older region, you know, if we made comments as far as, I want to kill myself, some of our parents may have looked at us a little bit different than what they do now, okay? And that's not saying that that's good, that's wrong or anything. It's just saying that it's a different perspective on these. I'm also seeing over the past couple months, relation to our political environment in kids. We're seeing increased rates coming up because of the news and everything, the social media effects that are going on and related to the political environment. I'm not saying anything political here, but we are seeing increases with that on the adult side as well. Suicide-related visits in the ED have been the most dramatic increase, going over from 0.9% to 4.2% of all pediatric ED visits. Like I said, a lot of this goes back to the social acceptance of mental health disorders. The increase in mental health related ED visits is evidence across different age groups, including children, adolescents, young adults, with the largest increase in adolescents. Revisits in the ED have been a concern as well. So one of the things is I'm also a county coroner, okay? Kind of a little bit of everything here, yep. So I'm a county coroner. One of the things that I've noticed in trends, and we do a suicide fatality review, is a lot of these patients actually were seen in the ED within the past 7 days, okay? Or they saw some type of a provider in the last 7 days that has contributed to this. So we have these return visitors that are occurring. Disparities across services as well. How many people are in rural communities? Okay. More city, urban, okay. You're gonna see more of these rates in the rural areas where the socioeconomic effects play into this as well. Let's talk about brain development real quick. So does anybody know when the brain actually fully kind of develops for a female? For emotionally. 21 is what it says. For males? Okay, I feel attacked at this moment. But it's actually 30, okay? So it is 30. And if you've not watched TikTok, it's very evident of that as well, okay? There's some things I've seen on TikTok and I'm like, oh, Okay, well, that explains why we have higher accident rates as well for men. So I know there was a comment a little bit earlier about they wanted you to kind of watch keeping phones out and stuff and recording, but I am kind of an interactive person, so I'm gonna go ahead and have you pull your phones out. While you guys are doing that, this is definitely placing a strain on all of our EDs, right? These pediatric visits are placing a strain on all of them. So I'm gonna give you kind of some resources to go. I'm a nerd. I really like research. So these were the two most current up-to-date research articles that I found that kind of may help you with some of your treatment and management as well. I'm not gonna bore you and go through every single one of these details. I'm gonna let you guys have some reading a little bit later to take home. See some people still kind of taking photos of it, so I'll wait a minute.
Do you have to take both?
Both of them are separate articles. And you can always, at the end, get with me and I can give them to you more detailed as well. How are we progressing in handling these cases? I promise we'll get to management of them. But one of the things I want to point out is who in the room has been a nurse over 10 years? Okay, go back. There's a lot more in here than I expected. Okay, go back to your initial training. How much training did you guys get in mental health? Zero. In mental health, in general.
10%, just 10%.
Yeah, very minimal, okay? And nobody really got, did anybody get true mental health emergency experience, or was it more of just a long-term general? You did? How about anybody 5 years? Nurse for 5 years? Did you guys get anything? More? Did you feel like you got more? How about nurse in the past year or so? Did you feel like you got a little bit more? No. We've really not kind of progressed at this a whole lot at all, okay? My nursing education consisted of going to a state hospital, and I actually spent only 4 days there. That was
2 days.
2 days.
Yes.
So mine was 4 days. She had 4 months. I had 4 days, okay? So talking about pediatric mental health experience, this is my son Everett. He is 2. I kind of miss him right now. So me and my husband are adoptive parents. We have 2 boys. Everett was born in utero on a couch, exposed to heroin, meth, fentanyl, a little bit of everything, okay? Everett lacks expressive speech. He is really good about receptive. I can tell him, go close the door, you know, go to the fridge, get me something, go bug your brother for a little bit, whatever. The problem is he can't do the expressive. So he gets very, very, very frustrated, okay? Does anybody have toddlers in here? They can get very frustrated, can't they? So imagine if you can't speak at all, okay? Looking at pediatric mental health, remember our brains are not fully developed yet. So when we start getting into these points of crisis and we start really not understanding what's going on, we're in complete overload, okay? Coping mechanisms aren't really developed until we get to adulthood. So we're really getting into that point of just being completely overwhelmed. ADHD kids are entirely worse on this. Because remember, it's like a bunch of sounds, a bunch of stuff going on that's just basically overstimulated, okay? Remember that ADHD kids also on their emotional development and even their academic development may be a couple years behind, okay? There is some research on that. I don't want to go too much into it, but it is a good read. Mental health topics. So primary versus secondary complaints, chronic complaints, frequent visits, making sure you're getting a good history, okay? There's so many segments of mental health diagnosis, acute versus chronic, psychopharmacology, which I love. And I know, do the APRNs, do they work in ER or urgent care? What's your guys' kind of setting? Urgent care? ER, okay. So You can see these in either setting, and it's important to realize that. How many people have a lot of patients that come in with complaints of abdominal pain? Yep, abdominal pain. So working in primary care where I was seeing a lot of patients for behavioral health issues, I would see these frequent ED visits for abdominal pain, abdominal pain, abdominal pain, abdominal pain. 0 mental health assessment completed during these, okay? No questions at all were really asked other than, oh, I don't see anything, or constipation was a big one because there was stool on the x-ray when there's not really, the constipation may be a secondary complaint. So getting a really good history on what's going on is super important. One thing I also want to point out with this is, who is our common complaint of abdominal pain? Female, okay? Females do have a higher rate as well. Remember when you're questioning them and getting into them, they can be, and I don't want to say manipulate because I feel like that term is not necessarily the term I'm looking for, but they may not be telling you completely what's going on in the history, okay? They may be kind of bringing stuff back and trying to hide stuff because they're a little bit smarter on things and trying to hide them, okay? So detecting the problem, screening. Here's another QR code for you, okay? So these are kind of a toolbox per se. So you're gonna be making sure that you're paying attention to them, being honest with them, whether you're doing PHQ-9s or GADs or whatever system you guys are using within your ER or urgent care, if you're doing an urgent care. If you're not doing it in urgent care, some type of mental health assessment, probably a good idea to document it, because if you miss something, urgent care, you're still at risk for malpractice and lawsuit, okay? Pay attention to when these kids are filling these out. Do you guys ask the questions verbally, or do you have something you circle? Verbal. So if I ask you that question right now in front of your parent, how are you gonna respond? You gonna be truthful with me or not truthful?
Not at all.
Not at all truthful, okay? I have laminated sheets that I use with the questions on them, and those dry erase markers that we write our names on the board with, does anybody actually use the dry erase marker? No? Okay. Well, the dry erase marker that we write our names on the board with, it's a simple thing. Just give them the piece of paper on a clipboard, have them circle the answers, and that's your answers. They're not having to ask in front of parents. You don't have to ask parents to leave the room, and making sure that you're getting the appropriate answer. Watch how they're answering this as well. Can they read it? Can they legitimately read it, and do they know how to answer it? Okay. I've asked parents where I've kind of detected something's off, I've asked parents to leave the room. I've never had a patient's parent refuse. Usually what I say is, hey, there's coffee right over there. Will you go grab a cup of coffee? I just got a couple questions. I want them to really be honest with me about it. And I'm like, oh yeah. Or I'll be like, Coke machine's over there. If you feel like they're lying or they're not answering it, do you document the results or not document the results? So it's kind of an iffy area. I document the behavior that I noticed, okay, and the behavior that's going on. I don't document false BPs. I don't document, whenever they import over, if I think it's wrong, I don't put it in there, right? It's not appropriate. So you can always just put, unable to get a good assessment, and make sure you document it that way. Look at your past visits as well. If you're a provider, make sure you're looking at their history. Does New York have a state registry where you can see other ED's visits? For opioids? So in Indiana, we have what's called iHigh, and it's all the health systems integrate into one. So I can go into iHigh and look at the other hospitals' ED visits, where I've seen a patient may have been seen for abdominal pain 5 times, okay? Make sure you're utilizing those resources if you have them. or if you can see general care notes, maybe urgent care notes to see if they're being seen elsewhere. Watch for anxious emotions. And like I said with parents, especially in New York, you guys have a little bit of a rate of it. Watch for trafficking. Okay? Trafficking is a huge one. If they're coming in for complaints of abdominal pain and there's nothing really there, look and see who they're being brought in by. Are they being brought in by dad multiple times in a row? Make sure you're documenting that, who's bringing them in. All right, ASQ toolkit. So anybody that's ever done peds, this is not ages and stages. So there's two different ASQ. The ASQ toolkit is actually a suicide screening, okay? While you're all scanning this, in my years working with kids, I've always been asked, how do I get along with them? And no, it's not because I'm mentally the same age as them. So before any of you guys get those ideas, okay? I'm really just very straightforward and blunt with them, okay? That's a majority of what they want. They don't want to be like babied. They don't want you to be like, oh, I feel so bad for you, or I'm sorry this happened to you. Typically, they can detect that as like falseness. So as nurses, we want to be comforting and we want to say, hey, you know, I'm really sorry this has happened to you, but honestly, are you being sincere in your delivery of that, or are you saying that because you feel like you have to? So kind of practice those. One thing that I always like to say is, hey, I appreciate you sharing that with me, or thank you for sharing. That's a better response than I feel bad for you, or any of those. Or bruh. Kidding, do not call anybody bruh, okay? 5-year-old, my 6-year-old, he called me bruh the other day, and I was like, we're not going there, okay? Not at all. Motivational interviewing, I'll hit that as well, is a good thing to be able to do if you've not done that class before, okay? So this is what will pull up if you scan that QR code. So you'll click on, and you can go through and use these for anything. You'll click on Youth ED and Script for Nursing. Okay, this is what will pull up. This is a good thing if you're in clinical education to use kind of as a scripting and making sure that they understand. Make sure they're comfortable. Like I said, I cannot reiterate that enough. Making sure that they're comfortable in anything that you're doing as far as that. Go back. We're going to click on third option here, which is the screening tool. I just have this honestly printed out for me, okay? It's something that I do when I go in as a provider, and these are the direct questions that you're asking, okay? Make sure, like I said, just be blunt with them. Have you thought about killing yourself, okay? Don't try to finesse it at all. Just be direct, okay? Have you had thoughts about killing yourself right now? Is there a plan? This can also be sent through your EHRs typically to the patient's cell phone, okay? And they're able to answer these questions directly from there. From triage, I gave this kind of along this talk in San Diego for ENA, and I had somebody kind of connect with me. They integrated all their screenings into their triage process. So now when the patient does their vitals, gets the initial triage, they go back, they sit down in the waiting room, and then they get a text message of surveys to fill out. It goes a lot quicker. Does anybody have that?
We need that.
It is awesome. It is awesome. It's like the pre-registration that you guys get for your appointments. Next one we'll go on to is second option. I'm not going to display it up here because it's a lot. This is great to take in the room, print, discuss, kind of on the go afterwards. So I'm giving you guys a lot of resources, I know, but I'm not one to stand up here and go through everything in detail. So All right, so we have a problem. Patient comes in and says, basically, I'm going to commit suicide. Legit, I had a patient look at me, and I'm doing their assessment, and he goes, God just told me it's your time. And I went, oh, okay. And then he looks at me, smiles, and says, I'm going to kill you, bye-bye.
Oh, great.
And I'm like, oh, just went completely sideways. In reverse of what I'm saying, remember to consider that mental health presentation may be primary complaint caused by secondary complaint, okay? There's no documentation, or there is some documentation of acute psychosis by COVID-19, hypoglycemia, electrolyte imbalances, meningitis, thyroid, which you guys just heard about, drugs, and so many. So just because they come in and say, I'm gonna kill myself, is that truly what's going on? Do they know what's going on, okay? Is there a secondary complaint? So steps to gaining control with this, and all the data supports this structure. Non-pharmacological treatments, pharmacological treatments, and restraints. If you jump straight to restraints, just be super cautious with that, okay? We have to think of our environment beforehand. Before these patients hit our rooms, think about your environment and where you're taking them to, okay? When we assume, you have to think about where you're taking them and making sure that you're taking them to the appropriate place. If they're completely in an acute psychosis period, are you guys taking them to the trauma rooms? No. Some places do take them to trauma rooms. Those are typically the worst places to try to deal with these patients because it is the most stimulus, it is bright lights, it is everything going on. So make sure you read the room. We all typically have the great ability to do that, except for some people just cannot read the room. Some of those nurses you know cannot read the room at all.
Sometimes it's availability.
Yep.
What's available in your ED, because sometimes you're not situated for somebody who's actually psych is crowded. Sometimes there's not even bed, you know.
Yep.
So sometimes it's what's available.
And remember, when you're reading these also, that triage is not the area to do your complete reading of these, okay? Sometimes it's the point where you just gotta read and understand something psychiatric is going on here. Somebody's gonna need a lot more time to deal with them, okay? Our ESI doesn't play in that effect, but the nurse's brain has to play into effect of that. Like I said, be supportive, engaged. What is your guys' policies on when they come into the room? Are you taking everything away from them?
Yes. Including clothes,
So we
everything.
take away triage. We can't bring them right into the back because, you know, I work in a city hospital.
Yep.
And they all have to be screened for weapons and things like that before we can bring them safely into the back.
Okay.
So it does take, you know, a few extra minutes. I mean, I understand the concept of wanting to do that and get them to a quiet place as soon as possible. But in a city,
You can't. You can't. It's about your nurse safety as well. But understand, read the room too, okay? Depending on what they're coming in for, if you give somebody a gown, no blankets, nothing, put them in a cold, empty room, do you think that's gonna set off? It's gonna set them off a lot. So there is those things where you just can't do that because of nurse safety, but consider that. How high of a risk are they? Quiet rooms are typically triggers. Would you guys agree to that? You sit in a room, it gets something that triggers you. Something we installed is we have little speakers in our ceiling that just play white noise, okay? White noise doesn't do it for everybody, but it was a simple thing they added inside our hospital that just creating some type of noise, it also covers up all the alarms, everything else that's going on. So if you guys have separate psych rooms that are completely quiet, talk to your administration, or if you're an administrator, consider just putting a white noise speaker in there because it does help. Ask them if they want to be alone or not be alone, okay? Some places have sitters, some places don't. Some people, when they're in these stages, they want to be left alone. Don't touch me, don't talk to me, let me just kind of comprehend what's going on. Going back to Everett, when he's in that overload phase, he needs to be able to calm down and get to a spot. If you put mom in the room screaming and be like, I don't know why you did this, I don't know why we're here, it's just gonna make things worse. Patient has the right to kind of be by themselves, and explaining that to the parents, you can be by yourselves. I've had some patients that have been extended stays for boarded that have been there by themselves. Depending on your hospital policy, if they're not a true threat and they're there for whatever, consider your volunteers, okay? Some hospitals allow for volunteers to go in there and play games with them or just kind of sit with them, talk with them, watch TV. The presence of another person can have an impact. Be direct, ask them about it. Chaplain, not everybody is religious, but it is something I offer my patients, is to be able to speak with a chaplain. It's completely up to them. Lights are a big one, okay? Lights are very stimulating. Dim your lights down. If patients are stimulated, dim those lights down, bring them down a little bit, it makes it a little bit more comfortable for them. I have an app on my phone. It's called Insight Timer. If somebody's gonna be in the room with them, it's an option for it. Have you guys heard of Insight Timer before? So it's just, there's an anxiety, there's guided meditations, those types of things. If a parent's in the room, I've told a patient, I'm like, look, give this 5 minutes, just try this. You know, parent downloads it, I play it with them, and it actually chills them out. Usually if I'm like, look, I'll make a deal with you. 5-10 minutes of just listening to this, I'm gonna go get you a Coke, sandwich, I'll be back. And a lot of them have said it feels better. Primary care, urgent care, when I've had patients come in with complaints, I'll do it. Yes, I did work in a Trauma One center for a while, and I preferred a little bit of noise in that area, no matter what, because I felt like it just was calming to everybody. Okay, so OSHU, we have our hands full. Remind you read the room, okay? There's certain aspects where you can try some of these non-pharmacological things of changing lights, sound, getting calm environments, removing people from the room if need be, and getting them calmed down. But there's also to the point where you can't handle what's going on. There's just no resetting this at all, okay? Once again, make sure you're minimizing those noises. I cannot tell you how many times that I've walked into an acute psychosis phase and the nurse is trying to get a blood pressure. Like adamantly trying to get blood pressure. And I'm like, do you think you're gonna get a legitimate one going right now? Like, what's the point of making them feel more constrained? Let's back this down. Let's diffuse the situation a little bit, de-escalate, and then we'll try to get vitals, okay? Consider that. And that's, once again, it's just reading your room. Security is a great tool, but it also can be a horrible tool. How many people have had security with the radios blaring? Drives me absolutely insane. They come in there, and I love my security officers, but they come in there, their mics are blaring, and it just creates more of a stimulus, okay? Ask them about earpieces to put their earpiece in. Majority of them have earpieces, or if you're admin at that hospital, ask if your security people can get earpieces. It makes a huge difference in that. Consider the amount of people as well. We all know that people really, really like attention in certain aspects. So swarming these people sometimes is what they want. Try to read that room again and determine, is swarming this room really a good idea? Okay? Is it gonna create more issues than just standing here and calming down? I love my autistic kids because they're like superheroes. They've all got their special abilities and all of that. But I don't know how many times I've walked in and I've said, please just give me the room. And I've had a security officer look at me like, what? And I said, out of the room. And I sit on the floor with them, okay? It is a complete flip around with that kid. I am not above getting on the floor. I've laid on the floor with kids, and it does change them, okay? read your room, get back down to their level. Make sure, yeah.
I was going to say, with most agitated people, I found, having worked in inner city ERs, in peds, even agitated parents, if you sit down next to them, when you get down to people, don't ever talk down to people.
Oh, yeah.
Whether they're kids or parents.
Yep.
It works.
Majority of the time I sit down. I've actually told a kid, I'm like, if you don't want to sit in the bed, get on the floor, that's fine. I'll sit with you. I'll lay on the floor with you. I've played games with them while I've been doing their interviews. You know, I understand a lot of us don't have time, especially if we're in the city, but making sure that taking that extra time right then may actually get them out the door a little bit quicker, okay? Introduce yourself. Introduce yourself multiple times. Introduce yourself every time you walk in the room. You walk in and say, hey, I'm Brad, I'm the nurse practitioner that's be taking care of you today. You come back a little bit later and be like, hey, I'm Brad, I don't know if you remember me from earlier, but I'm just following up with you. There may be an hour before you went in the room last from that point of agitation to do it, okay? Make sure, if the patient is really agitated, introduce yourself multiple times during that time, okay? Just take time with them. That's how I can't emphasize enough on taking time with them. Going back to your lights, what do lights do to the pupils?
Agitates them, drives them crazy, I feel like, makes them seem exposed, feel very exposed.
Okay, so when people are stressed, where are their eyes? Typically dilated, right? So we have bright lights in the room, dilated eyes, go to the eye doctor, walk out in the sun, what happens? I'm mad. Where's my cheap sunglasses that you were supposed to give me? Okay, but you got those dilated pupils in those rooms with bright lights, it's gonna affect them. Bring it down. I've walked in with my cell phone in my back pocket playing soft music, okay? People think I'm completely insane, which is fine because I love psych. It's fine. But I went in with just light music on my cell phone, and it's played an effect in kids. It's grabbed their attention. Once you get back down and you're calmed down, make sure to go back to slide 8 and think about your differentials. Okay, what's actually going on here? Remember, these aren't trauma, these aren't STEMI patients. We need to shift gears a little bit, and it's hard for us from a go, 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 go to bring it back and really deal with these. Pathways. Have you guys heard of clinical pathways? Yes. Do you guys know about any of these clinical pathways? So the one I use typically is University of New Mexico, CHOP and CHOP. These are the two that I've reviewed with my collaborating, and we have a collaborating physician. And when you open these up, it gives you a list of different pathways for different things. And these are great to have right there, especially as a new NP or even as a nurse, to be thinking ahead and see where you're going to be heading to. In New York, you guys actually have a couple, and you're going to have to help me with the names, okay? Upstate, Goalies. Yeah, how do you know? Okay. Children's Hospital of Montefiore. Is that where you're from?
No, 15 minutes away.
Yeah, so they actually have clinical pathways, and then I won't screw this one up, Stony Brook, is that right? They're all in New York, and they have clinical pathways, okay? If you go to my derm lecture in a little bit, we'll talk about pathways as well, because there's dermatology pathways on these, okay? Both of these have dermatology pathways that will help as well. A lot of information, but this will have everything that you need. So your non-pharmacological are up top. You'll notice that basically they're suggesting the same thing. Reduce stimulation, dim lights, favorite music, TV show. Watch your music, okay? Because if you choose music that is gonna remind them of their ex, that's a bad idea. okay? Bad idea. Child life, some people have child life, some don't. We actually have just a small little box of like toys, like what is the thing with 2 dials, it's red? Etch-a-Sketch, yes, sorry, I cannot believe I forgot that. Just an Etch-a-Sketch that they can sit there and play with. Fidget toys. I talked my ED into just getting some fidget toys, that not the ED I'm at currently, but another ED, and we just gave some of our psych patients little fidget toys. They're cheap, easy off Amazon, and really can play an effect with kids. Verbal support, make sure you're keeping 2 arm length distance. Once again, read your room, okay? 2 arms is okay sometimes, but also, I'm not a runner. So some of these kids, I gotta keep a little bit more of a distance, okay? Keep a calm demeanor, facial expression, and posture. It is really hard for me to control my face sometimes. Take a deep breath before you go in the room if you can't control your face, and think about how you're presenting to these kids. If you've been on that kid multiple times and you're like, look, this is not gonna be a good working relationship, speak up, because you can send that kid into a bad area. So speaking a little bit on the agitation uncontrolled, on the MDR and swarm, looking for causes and your medication therapies and stuff, make sure you read your room as well. Again, I cannot emphasize that enough, because swarming these patients with people can agitate them. This is a little bit different than a swarm. Who can consult pediatric psychology here? Really, I mean, 1 in the city. It's about what you get. Some states have, and I couldn't find one for New York, but we have a line that we can call at Riley, which is our pediatric center, and talk to one, but it's not well advertised because it's used a lot. So undifferentiated, Versed, Zyprexa are kind of the 2 that are kind of suggested. What do you guys typically use currently? Either of those? Zyprexa, okay. For developmental delay, autism, Zyprexa. Consider asking the patient also what they take at home. That is something that's commonly missed. Because typically psych will send them a PRN medication. Ask them, what do you take at home? Ask the parent what they take at home. Restraints, so this is their restraint policy. I'm gonna defer you guys back to your restraint policy. Make sure that you're reviewing that and you know your restraint policy. Look at your history, what's worked for them in the past. Once again, this is where I go to iHigh and I'm like, hey, okay, benzos did not work for them in the past. They had it like 3 times before they got to what they needed. You need to make sure that it isn't diabetic, drug-related, so they can send your patient your whole day into a spiral. Okay, I've seen these psych patients come in where they think they're psych because they have a history of psych, and it's something completely different, and then they treat it with a med, and it's just downhill. Ketamine, does anybody go to ketamine? Okay. Ketamine was really big for a while because it was kind of the new hot topic that was going on. But the thing is, there's no clinical evidence to support it currently. None. So if it's on your radar, consider taking it off because there's nothing to support it.
But I feel like they're using ketamine now more than ever for a lot of things.
How many lawsuits are going on over it?
Yeah. I didn't know that part.
Take a
Because
look.
I feel like in my ED, there's a lot of focus for even the other side for ketamine that we're using for different things.
Yep. There was a lot of use for ketamine for a while and a lot of things, but there's several states that have ongoing lawsuits in regards to ketamine and off-label use. Okay. Benadryl. Does anybody use Benadryl? What's the side effect of Benadryl? Agitation. Yeah, complete opposite, especially in kids. So there is some people that will just go straight to Benadryl. It's okay for anxiety, abdominal pain, and considering those. But just keep an eye on it, because if they've had a Benadryl before, make sure that they're not going to go complete opposite on you. Ask the parent, have they had Benadryl before? Oh yeah, it knocks them out. Okay, well maybe that's a good option at that point. Hydroxyzine. Yeah, hydroxyzine. Hydroxyzine is something that I also send PRN home. I just send them a couple to help kind of control and get them down. This is another chart, won't go very deep into it because you have the resource, but what's one thing that you kind of notice here that you probably should be doing on these patients that a lot of patients don't do if you're going to be given meds? There's a lot of QT prolongation going on here, okay? Especially of what's going on within your, some of your serotonin stuff. Make sure that you're checking EKG and consider that. If you're going to be given Haldol, I would suggest probably making sure that you have an EKG at least after administration, okay? And documenting, EKG completed due to Haldol, risk of QT prolongation. Almost skip. This is back in CHOP as well. So we've calmed down kind of what's next and gained control of the situation. I always set guidelines, okay? Making sure that once we're calmed down, these are my expectations of you, and this can be your expectation of me while you're here in my emergency room. I don't deal with cussing, I don't deal with screaming, hitting, any of that. Very direct. You give me respect, I'll give you respect. You want a Coke, I'll give you a Coke. But if you're gonna yell, scream, cuss at me, we're not doing that. That's not how we work here in the emergency room. Just because you're not the parent doesn't mean you're not the parent in the ED. Make sure you're setting those guidelines, okay? Throwing items as well. One thing I do want to hit, so I've went in before and I've had a boarded patient where the patient's been there and they've been doing great, okay? I go in at 11 o'clock and I'm like, oh, hey, I'm sorry you're still here. Unfortunately, I'm here today too, but we'll figure this out together. Have you had lunch yet? No. And then I'm like, do you want a candy bar or something? I'm not opposed to going to get them ice cream from the cafe or a candy bar for 12 hours of them being nice to me, okay? Well worth it, well worth it. I had a kid that was discharged after telepsych, committed suicide 24 hours after leaving my ED. He left a note and told me that he really appreciated me being his friend. I got him a waffle cone. That's all I did, and it made a huge impact on him. Revisits, as far as administrators in the room, educators, or anything like that, make sure that you're looking at these revisits and make sure they're getting follow-up. Look for hindrances in care, referral to social work, because if these patients are coming back and back and back, or back and back, sometimes it's a parental issue of transportation. The parent's not following up. So how do we overcome that hurdle? Get that over to social work and get it figured out, because that's a quick thing that you can do, a quick referral to social work and let them figure that out versus continue to see them week after week after week. Safety plan, got about 7 minutes here, so speed through it. Have you guys heard of safety plan before? Not this? So there's several apps like this. This is something that towards the discharge time, when the patient gets their phone back, I start having them download safety plan, okay? This gives them the ability to kind of get things rolling. Warning signs, coping strategies, reasons to live, contacts, places for distractions. Warning signs, this is your education, your discharge education. You're getting them to the point where they're thinking, okay, these are my triggers. I've not really thought about it, but what's my trigger? What's triggering this situation? Oh, my boyfriend's triggering this situation. Education side, have them add in these warning signs. Coping strategies. This can be anywhere from talking to someone, cuddle a pet, take a nap, watching funny videos, working out, like I said, cautious on watching or listening to music because I remember an ex-boyfriend and stuff, ex-girlfriend. Reasons to live. This is important to review with them and making sure that they have identified the reasons why to live. Okay?
But if someone is hopeless, will they be able to identify any reason with you?
If they're what?
If they're hopeless, if they're like, at that point where they're like, I don't want to be here, there's really nothing here for me.
So typically, if they're at the point of hopeless and there's no reason for them, they're going to be admitted. Okay? This is more towards your discharge time. Yep. This is more of your going home time. Contacts is important because it's that phase where I'm starting to spiral. So who do I need to contact? Who is my support people? Evaluating who that is. So mine, this is what I just downloaded. Call Jeff, Michelle, Brett. Jeff is my husband. That's the last person I'm calling now at this point. Because he's complete panic phase anyways, and yeah. Kids screaming in the background. Find urgent cares, find emergency rooms. Why is urgent cares on here is why I've been asked. Some places don't have ERs, some counties. Your urgent care is the closest thing that they can go to. And that's why it's on there, is to be able to find that close resource. Call emergency number, call helpline, text crisis line. One thing that I want to point out is making sure that you're giving them in their discharge a list of phone numbers. I have an auto text. Some facilities have a list of them, but I see a lot of kids that come in, or even adults that come in, that weren't provided any resources. Check with your telehealth psych provider or your psych provider to make sure they're getting a list of phone numbers. Places for distraction. This goes back into calming people down, identifying whether it be a park, whether it be somewhere that they can go to kind of bring themselves back down. Like I said, make a list of your own local resources to give them. There is always the problem of insurance and who is available on insurance and who's not available on insurance. I give the parents every single provider I can. Because just because they may not be on their insurance provider, they'll still seek help. Okay? Telehealth is good, but a lot of that one-on-one reading that occurs really needs to happen, especially with kids. So make sure that you're kind of including those into there. If this was something I didn't know, can a pediatric patient, check out or AMA themselves? Can the parent AMA a pediatric patient out of your ED?
Yes.
Depends on the type of patient. Know your law, because when I worked at a rural ED, we were always told, yeah, they can sign them out, that's fine, AMA. Found out when I went to the pediatric hospital, no. Absolutely not, they cannot. Right. There's points that you have to get law enforcement and DCS involved to keep that patient in the ED. So, got about 2 minutes left. Sorry, I kind of sped through that a little bit towards the end. This is my contact information, my cell phone number, my email. Feel free to contact me with whatever you want. Ask me questions. If you need a copy of anything, I'm more than happy to give it to you. I've had patients call me about their own, or people call me about their own kids and just been like, hey, what do you think? And I mean, we're all family as ER nurses. I'll kind of walk through things with you and be like, hey, this is a resource in your area to go to, or this is a provider. So, all right, any questions? All right.